literature that we have over the last 10 to 12 years and how the available literature has probably changed the way we manage some of our patients. Because 10 years ago or 11 years ago when we started injecting, we didn't have the experience of what really happens, what is the cause, what is the natural cause, or what is the behavior of this disease. But today, I think there is so much of material available, not only from literature, but also from personal experience. So I think 2000 was a landmark year when we had the first level 1 evidence treatment for subfoveal age-related macular degeneration, that is the photodynamic therapy. But I think the landmark as far as the treatment of wet AMD is concerned is the development of the anti-VEGF therapy. That was a landmark because for the first time we had a treatment modality with which we could get improvement in visual acuity. So this is the landmark trial. There were 2 landmark trials, the Anchor and the Marina, one looking at ranibizumab versus sham. And in both these studies, there was about 38 to 40% of patients noticed about 15-letter visual improvement. So that's a major breakthrough as far as the management of this particular disease is concerned. So, on this particular graph, I think is a very famous graph. I think it must have been shown the maximum number of times across the world in various presentations where there was a distinct improvement in visual acuity. But the downside was patients were injected on a monthly basis. That is, the patients had a monthly injection, which probably in the real world is not possible. And that was the downside as far as this particular trial was concerned or the results were concerned. And the question arose as to whether we will be able to replicate this into our day-to-day practice. So, and the most important development, I think, is the use of intravitreal bevacizumab. Because this particular article, I think you should all read. It's a wonderful article as to how Philip Rosenfield really thought of this particular process, and finally it did happen. And probably this has made treatment accessible for the common man, especially in countries like India, where 95% of patients who are being treated are paying through their pockets. I think that's the biggest challenge that we have as far as the management of chronic diseases is concerned. Therefore, they looked at lesser doses, that is the quarterly dose, the EXCITE study, and also the PEER study. And in both these studies, they found that the results or the visual improvement and the results were not comparable to the monthly injections, and therefore the quarterly dosing was really not sufficient as far as the management of this particular disease is concerned. Then came the Pronto study. This was not a big trial. This was a pilot study. It did not have another arm to compare. But nonetheless, the Pronto study, which was as is needed treatment, showed that the results were comparable to what was achieved both in the Anchor and the Marina study. Therefore, world over, I think this as is needed treatment was used for many years as far as management of disease is concerned. And we really do not have data as to what is the treatment pattern in our country. But then if you see the Western world, both in Europe and in the United States, we get continuous data as to what is the practice pattern, at least in a sizable number of retina specialists. The View 1 and the View 2 trials are very, very important, I feel, for 2 or 3 reasons. Number one, the largest number of patients were recruited in these trials. This, of course, trial was with aflibercept versus ranibizumab, but nonetheless, the number of patients that were enrolled were nearly 1,500 patients if you combine both the View 1 and View 2 together. So number one, they looked at a larger number of patients, and number two, after completion of the first year, in the second year, they used the as-is-needed treatment, keeping something like a capping, that is at 12 weeks, all patients received injection. Therefore, there is a distinct difference from the way the Anchor and the Marina was done and the View was done. And View also was looking at the new paradigm in the management of wet AMD, whether lesser number of injections will suffice in the management. Therefore, if you look at the View extension, therefore that's what I said, the CAP PRN, that's a new terminology that came after the View 1 and the View 2 trials, where irrespective of what the situation is, at 12 weeks you inject. So, but then you're extending the duration of the injection, and this is a very important development as far as the management of the disease is concerned. Therefore, if you look at the View extension, where patients were stretched on to 4 years, and if you see here, throughout between 2 and 4 years also, in spite of the lesser number of injections, and in the second year actually the average injections were about 3 to 4.1, therefore the visual acuity improvement was reasonably well maintained. Therefore, if you look at the treatment pathology as far as wet age-related macular degeneration is concerned, we have the monthly, we have the bi-monthly, we have the quarterly and the PRN, and probably the PRN is the one that is followed in a larger, more commonly. But then there are so many challenges as far as the pro re nata treatment is concerned, because patients have to, although the number of injections are reduced, follow-ups continue to be there. Patients have to come to you on a very regular follow-up. And I personally feel in my practice now over the years, now after seeing many of these patients, earlier when I started treatment 10 to 11 years ago, after the first loading dose in the macula was dry, I should call them after 3 months. But then I realized when they come after 3 months, most of them are coming back with significant recurrences. Therefore, after the 3 months, they need a monthly checkup. They may not need the injections, but ideally the patients have to come on a monthly basis, at least for the next 3 to 6 months, to see the behavior of the disease. Therefore, that again is a great challenge as far as travel is concerned, mobility is concerned, etc. And cost of treatment, socio-economic basis. Therefore, there are a lot of issues as far as the management is concerned across the world, not only in India. So in this context, actually, I thought we'll just look at the behavior of the disease in 1 or 2 patients with a long-term follow-up as to what are the issues and what really happens when you do a pro re nata treatment. Therefore, this is the first case I want to show you. This is a patient who has been under my care now for about 6.5 years. Now, this is a patient bilateral disease, but I'm just showing you the left eye. So, patient was initially managed with a loading dose of ranibizumab. You can see here there was a significant improvement, and the visual acuity improved to nearly 6/9. But then after 3 months or 4 months, he was coming on a monthly follow-up. He has a recurrence after 4 months. And if you see this particular chart here, every 4 months he is getting a recurrence. I need a pointer here. This is the pointer. So every 3 to 4 months, he is getting a recurrence. You can see the dates there that tells you that he needs an injection every 3 to 4 months. But then suddenly about 5 months, he was lost for follow-up. And you can see here, there is a significant drop in visual acuity. You can see the cystoid edema and the intraretinal fluid here, and the visual acuity drops from 6/9 to about 6/18. So once there is the follow-up is lost, there is a significant decrease in visual acuity, and more importantly, intraretinal fluid results in dramatic decrease in visual acuity, and this is something that we have learned over the years as to what is the important sign in the OCT to tell us that probably these are patients who require more careful follow-up and more regular injections. So again, for a second time, he was lost for follow-up about 4 to 6 months, and again you can see here there was a dramatic fall. And this time, although he recovered, the visual acuity has dropped to 6/24. Therefore, from 6/9, he has reached to 6/24 over a period of 3.5 years. Basically because for 2 reasons. One is the need for injections is very frequent. Number 2 is difficulty for a very regular follow-up. Number 3 is presence of IRF results in significant drop in visual acuity. So this patient now is coming on a very regular basis. He is coming on a very, very regular basis, and he still, after about 5 years of follow-up, he has got a visual acuity of about 6/24. He has had about 11 injections, which is not much comparing the duration of the disease. But then, as I told you, there have been periods of lost for follow-up, which probably explains as to why the visual acuity has dropped to a reasonable extent. This is a second case which I want to show you, where a patient has been, this is a one-eyed patient, where a patient has mainly got fluid, serous macular detachment. There is no intraretinal fluid. He is also under my follow-up for nearly 6 years. Initially, he was treated with ranibizumab, multiple injections, but then at one point of time, he developed poor response to ranibizumab. That is what we call as tachyphylaxis. The mistake I made was I tried continuing the drug because it's a one-eyed patient, and in one-eyed patients I'm a little careful. I don't usually inject bevacizumab unless the patient is very poor, and therefore I persisted with a multiple dose of ranibizumab, and finally I shifted him to bevacizumab. There was no response to bevacizumab also, and finally I shifted him to Eylea, because with Eylea, with one injection, there was significant improvement. Therefore, something that I learned is that once there is no response to bevacizumab or ranibizumab, probably it will be better immediately to shift to a different molecule like aflibercept, which works in a different mechanism, rather than trying out a similar molecule in the same spectrum. And still, because we need to look at costs, because patients, if they are very educated, they keep coming to you for follow-up, but otherwise patients are lost for follow-up. So once he was switched to aflibercept, aflibercept, I again went back to ranibizumab because there is a philosophy that you can go switch and go back, but then that didn't work again, and finally again I had to go back to aflibercept. So the moral of the story as far as this particular patient is concerned, he is also on a PRN basis, but then he is maintaining good visual acuity even now, in spite of periodic exacerbation, basically because he is got mainly a serous macular detachment, there is no intraretinal fluid, and therefore in spite of over 4.5 years of treatment, visual acuity is nearly 612, 6.9. Therefore in this concept, these are two patients who were treated on PRN basis. They're coming for a regular follow-up, but this probably is not something that happens on a very regular basis where you need patients to come to you on a regular follow-up. Now these are two patients to whom I advise the treat and extend philosophy, because these are patients I feel who fit into my definition of treat and extend, which I'll come to later, where patients need very, very frequent injection. World over, if you see the ASRS and the European surveys, 70% of retina specialists have now shifted to the treat and extend, because it probably reduces the number of injections and reduces the number of visits. But then what sort of patients probably we can advise? TND is probably a question which many of us, there may be a difference of opinion. Therefore, I have just spoken to you about the two mechanisms of treatment. As far as TND is concerned, for those of you who do not know what TND is, you slowly start extending it by 2 weeks. That is, you make the macula dry and then delay the follow-up by 2 weeks, and then you inject and again delay it. So, and probably in most of the studies, it is capped at 12 to 16 weeks. So you are injecting, but then you're injecting when the macula is dry, but then you're increasing the frequency, the gaps by every 2 weeks, so that it's all stretched out over a period of time, and if patients are lucky, they may need only about 4 injections or 3 injections in a year. So there have been various studies which have looked into TNE. Some of them are prospective trials. The TREND and the TREX are true, but none of these studies follow a similar pattern. For example, in TREND, it is a loading dose of 2, whereas in TREX, it's a loading dose of 3. So it's very difficult to compare the results. Now, what sort of patients we can advise TNE? Because if you see the RCT trials or the randomized trials assessing TNE, in most of these studies, the treatment-naive patients, after the initial loading dose, they are immediately being put in TNE. Somehow I feel that should not be done, because we should study the pattern of the disease, because still we have about 10 to 15% of patients with wet AMD who may not need that many injections, and probably who after the first loading doses may not need an injection even for the first 1 year. Therefore, we need to identify patients. Therefore, after the initial loading dose, we have what is known as a maintenance phase during the first year, where we study the pattern of the disease, and during the first year or during the 12 to 15 months, if we find that nearly every 6 weeks or 4 weeks, you need to give an injection, and the recurrences are very frequent. Probably these are situations where in the second year or after 16 months, you can push them on to the TND mechanism. Therefore, you have the loading dose, you have the maintenance phase, and finally you move into the treat and extend. Now, there are some recent trials that have come, very interesting reports as far as the TND is concerned. One is the rival study, which has recently been reported. That's 24-month results have come, where in 281 treatment-naive patients, they are compared ranibizumab and aflibercept in a TNE process. They are actually, the primary outcome was macular atrophy and the area of geographical atrophy that comes in, but they found that as far as macular atrophy was concerned, there was no significant difference between the two arms, and there was no significant increase in the area of atrophy over a period of 24 months compared to the natural course of dry age-related macular degeneration. This is an interesting report. But then I was only looking at the need for number of injections. And if you see this particular here, if you need the injections, about 30% of patients, actually they could stretch it up to 12 weeks. About 30% of the patients, they could stretch it up to 12 weeks. One interesting information I got from this particular study is there was no difference in the number of injections between aflibercept and ranibizumab. That was quite surprising as far as I was concerned, because I thought once we have aflibercept, the need for injections may be a little less because it's a longer acting drug. But then anyway, 30% of the patients actually, it could be stretched up to 12 weeks. The other interesting study is what is the Altair study. This is a very interesting study from Japan. This is basically again using aflibercept, and here they have done it in about 40 sites. They had about 255 patients. They put them into two arms. One is the 2-week adjustment group, and the other one is the 4-week adjustment group. 2-week adjustment group means after the initial loading dose, you stretch it by two weeks like that. Whereas in the 4-week, they stretch it by 4 weeks straight away after this thing, and there was a capping up at 16 weeks. Now this is a very, very interesting study. And they have compared the results with the View 1 and the View 2 trials. Therefore, as I told you, there are two arms. One is the 2-week, and the other one is the 4-week, and they have equally distributed these patients. And basically, once there is, the philosophy is the same. That is, once there is a recurrence, they shorten it by 2 weeks. Once there is a maintenance, that is, you make the macula dry, you extend it to 6 weeks. At that time, there's a little fluid you are injecting. You again call them after 6 weeks. You don't make it 8 weeks. So when you see minimal activity, they don't stretch it to 8 weeks, but then you call again at 6 weeks. Again call at 6 weeks, it is dry, you inject, and then probably increase it to 8 weeks. So that is what is known as a maintenance. And then the shortening, if there is recurrence, they reduce it to 2 weeks. And the minimum interval 8 weeks, the maximum interval is 16 weeks. Now if you look at this analysis here, 24 months, you can see here number of patients with next interval determined as greater than 12 weeks, more than half the number of patients that were there in the study. That's quite a significant number. Therefore, in the Altair study, they have shown that probably with treat and extend, it may be possible that we may manage with about 3 or 4 injections on an average per year in large number of patients with wet age-related macular degeneration. And more interestingly, they also found that the visual acuity results were more or less similar with the View 1 and the View 2. So in this context, I thought I'll just show you one or two patients, two of my patients who have been with me for nearly 7 to 8 years. Now this gentleman actually is a one-eyed patient. Again, you can see it's mainly a serous macular detachment. It's something like a type 1 choroidal neovascular membrane. He was initially on ranibizumab, but then his recurrences were very frequent. Nearly he needs an injection. Can I continue for another 2 minutes? He needs an injection nearly every 4 to 6 weeks. And therefore, I finally shifted him to aflibercept and slowly shifted him to a treat and extend. And now, at this moment of time, he needs an injection once about 2 months. So once in 2 months, that's not a big stretch. But then as far as he is concerned, he is quite happy because it's going up to about 8 to 10 weeks. So he is quite happy because he travels a long distance to come and see me. Therefore, this is another patient again with a treat and extend, where initially with ranibizumab, she had about 14 injections in about 21 months, but then again I shifted her to aflibercept and slowly stretched it from 4 weeks to 8 weeks, and finally now she is able to maintain with reasonably good visual acuity. But in both these cases, it looks more like a type 1 choroidal neovascular membrane. I thought I should also say that another important area where there is a paradigm shift is the importance of rescue PDT in selected cases of CNVM, especially the type 1 choroidal neovascular membrane. Now this gentleman was on anti-VEGF for quite some time, but then again he needed a large number of injections, and finally you can see here with a combination therapy for nearly 2 years he had a treatment-free period. Now that's what is most important. It's not that it's not going to recur, but then when you get a treatment-free period for about 2 years, that makes a significant importance as far as the patient is concerned. And you can see in about 56% of the patients, they had a free period of a minimum about 12 months or about 15 months in large percentage of patients. Therefore, if you ask me a question as to what is the paradigm shift in the management of wet AMD, I would say that what we are looking now is longer treatment-free intervals without compromising on outcomes and balancing costs. I think that's the challenge, and newer drugs like brolucizumab probably may be an answer, or the port delivery and ranibizumab, if it comes, probably are answers provided the costs are tolerable as far as our patients are concerned. And most importantly, I think most of us have learned how to run a medical retina clinic. A medical retina clinic should have good optometrists. The patient comes in, has a good, best corrected visual acuity. They should have a small low vision clinic where patients are generally checked for improvement of near visual acuity. They get the OCT done, a color photograph done, come to the retina specialist, and patients should always come prepared for an intravitreal injection as and when necessary. With that, I think we can really improve the outcomes of our patients. Thank you very much.